Hey guys, I hope you're watching. I'm trying this YouTube Live for the first time. Let's see if I can get this figured out. So that link, I was hoping I'd get some sort of a thumbnail. Oh, okay. Let's see if that gets you guys on here. I'm going to share this out. You guys should see my Facebook feed right now. So trying, guys, just bear with me a minute. All right. Let's see what this does. So I'm going to see if I can open it up on my end. And what we're going to do, you guys should see me. Let me make sure. Yep. All right. What we're going to do is we're going to answer your question. And if this works, I've got big plans for you guys. I'm just trying to get it up on my phone so I can see if you guys post anything in the chat. I won't be able to see it on Facebook, but I can see it in YouTube. So feel free to chat. I don't want to butcher your name. I'm going to say Tarso. I hope that's close enough. Was feeling pain. And I'm gonna generalize a little bit here. You did an amazing job giving me information. But essentially you had pain, like as I'm looking here, you know, sometimes weakness, sometimes pain, not discomfort, but pain. I love that explanation. That explanation is really important. Not discomfort, but pain. In the back of my knee, when my leg is fully extended. So when your leg is fully extended, so in my mind, that's telling me that, okay, there's some sort of tightness, some sort of restriction going on back there. Now, to put the blame on a specific muscle, I just think it's kind of short-sighted. Now, I'm not saying anything negative about any clinician. There's plenty of clinicians out there far better educated than I. But just to kind of put context to what we're talking about here, I grabbed this photo. Now, it looks like a bunch of gibberish for most of us. But really, so when you're looking at the back of the knee, these yellow lines are the nerves. Then the red, these are cut muscles. And I just want you to get a sense for how many layers and how many things are actually behind the structure of the knee. So you've got the superficial muscle, which is the gastroc. Then you've got the soleus, which is the muscle below it. You've got all these little muscles that are running down in here, flexor digitorum. Up here, you've got the popliteus muscle. You've got the plantaris muscle. The gastroc, which is the biggest muscle that you see just under the skin. These guys are massive and they come down through here. And then, of course, you've got your nerves. You've got your blood vessels. You've got lymphatic vessels. You've got so many structures back here that to really place the blame of pain on one specific structure is just, you just can't do it. You're talking about a needle in a haystack. And I think, you know, we need to ask better questions. We need to look at this a little bit deeper. And that's where I'm going to go with this. So I'm not going to pretend that I have the answer for you because I don't. And I think this is one of those situations where you just say, I don't know. As a therapist, I don't know. But we're going to experiment. We're going to try things and we're going to figure it out. But in our clinical brains, it's just so much easier to say, oh yeah, it's this muscle right here because we saw it in the book. We dissected it in cadaver lab. Resected it, whatever the terminology. And if you would have found me 10 years ago, that would have been me exactly. I was a big biomechanist. I was a big anatomy. Everything had a structural component. It was just clean and tidy and easy to categorize. Now, 20 years in, it's just not that easy. So you said today was probing the back of my knee and he came across a tender area. Which, exactly, it's a tender area. There's lots of structures that could be producing the sensitivity you were feeling. He associated with that muscle. That's fine. He's kind of taking a guess, but I want you to understand it's just a guess. In addition, oh, sweet. What's up, Will? What do you think? For you, it was vascular. Yeah, like you're living this. You're in it right now, and you and I have had this conversation. Hey, tell me what you think of the YouTube live delivery. Um, so you were saying, in addition to that, when I lay on my stomach, leg flat, then raise it before I can get it bent to 90, I can feel the pain in the area across the bend of the knee. It's brief and I can push through it. So here's the thing with that position specifically, and I want you to think about this from a mechanic perspective. These muscles back here, the hamstring muscles above the knee, the calf, and some of these other structures below the knee, those are the muscles responsible for bending the knee the way you're talking. I would imagine the pain would initiate at immediately when you start to go from straight to bent, and it would continue throughout the range of motion. The fact that it's hitting you at a painful spot toward the end range tells me that it's more about something being pinched than it is about muscle function, the function of the muscle pulling. So that's kind of an indication to me that maybe we're not looking at the right area if we're thinking about a specific muscle. And I think you're on the right spot here. So this all came from a question I had. How do I know if the prosthetic was properly set, if it fits correctly? Absolutely. I cannot tell you, certainly, and Chris Easton will speak to this better than I, with computer-generated implants and surgeries, I mean, they've come a long way. But it's not a perfect science, and the prosthesis might not fit perfectly, and there certainly can be some pinching in certain areas. And if you are experiencing something that you feel is like that, doesn't mean there's anything wrong. It could be a totally natural sensation, but I would say that you are the only one who knows what you're feeling, and clearly you have the personal insight to really analyze what you're feeling. So I would bank on your guess over my guess as a clinician all day long in the clinic. And we don't know. We don't know if it's implanted correctly, if it's shifted, if it moved, any of that stuff. Even imaging is never going to be consistent. I asked him about it because as well as I'm doing, in this one area, it seems to be persistent and bothering me at random times. Random times is the thing that I zeroed in on for your situation the most. If I'm looking at pain and I want to blame biomechanics, if I want to blame a muscle or a bone or skin or nerve or something like that, it's not a random occurrence. It's a reproducible occurrence. I produce a movement, whether it's assisted, resisted, whatever. I trigger the response, right? The way I explain it to my patients in the clinic is if I open up a paper clip and I stick it in the outlet on the wall, I'm going to get shocked. Every time I stick that paper clip in the outlet, I'm going to get shocked every single time. It's a reproducible event. That is usually when you're looking at something that's specific to a tissue, a muscle, a tendon, a nerve, a ligament, whatever. When it's random, you never know when it's going to happen. Some days it happens, some days it doesn't. You do lots of stuff, no pain. You do nothing, lots of pain, and then everything in between. That, to me, says that we're not really dealing with a specific tissue pathology. We're not dealing with a problem with the structure. We're dealing more with either a chemical problem, which I'll try to get to, but I know I'm taking you guys longer than you probably expected. A chemical problem, or we're dealing with a sensory problem, sensation. Pain can be a warning signal. Pain can tell you something is about to break or burn or rupture. Pain is a motivator to get you to stop doing something. But pain can also be just a sensation that has no functional purpose. And your therapist needs to be able to determine, is this pain that's giving us good, useful information, or is this pain that's just hanging out because it's always been here? The other example I give in the clinic is if I pinch my skin for 10 seconds and then I let go, I still feel the pinch sensation. If I pinched it for 20 minutes and I let go, I would feel that pinch sensation longer. You've been dealing with these pain issues around the knee before surgery, during surgery, after surgery for so long that even if I had a magic wand and I instantly changed everything mechanically wrong with the knee, there's still a good number of the population that would continue to feel the pain even though there was no problem. And the studies for that go back to the individual who had a foot amputated. They don't have a foot, but they have foot pain. There's lots of great information out there on sensory pain that's not related to tissue damage. So random times is the big thing for me to say, well, maybe it's not a muscle problem. Maybe it's not a prosthesis problem. Maybe it's a sensory problem, and we need to desensitize that tissue at different movements, different joint positions, under different loads. And then you go on to say the pain is rather elusive, again, sensory. Like I just raised my leg when laying on my stomach at first attempt. I could clearly feel the pain, but then I did it, got past it by bending the knee as far back as I could. The next several attempts didn't trigger the same pain response. Now I could make a case for mechanics here again, saying that when you flex the knee the first time, you've got new grooves, right? It's like an old worn out couch. You've got your butt groove in that couch, and then you get a new couch and you need to make your butt groove again. So in the back of your knee, you had grooves and your knee moved in a certain pattern before surgery. Now you have a new knee, you have new patterns of movement. So it's reasonable to say that when you did that first one, something shifted. It gave you a little bit of a new sensation that your brain perceived as pain. Okay. You did it 3-4 more times, no pain, because now the brain was accustomed to that movement pattern. It's a new movement pattern. Long story short, and guys, I apologize for keeping you on as long as I did, but I think we need to start to understand that absolutely, pain can come from lots of different things. Pain can come from tissue injury. If I cut my skin, if I smash my thumb with a hammer, I feel pain, okay? Pain can come from chemical changes. And this is really important, especially this time with everything that's going on with the coronavirus. I want you to think back to the last time you had a cold or, viral, bacterial, whatever it was. You didn't necessarily know you were sick, but what did you feel? You felt pain. You felt pain in your muscles. You felt sore. You felt fatigue. Like for me, it's always my left thumb and my right knee that just start to hurt. And then all of a sudden I realize, I'm catching a cold, and then I get stuffy head and runny nose and all that stuff. But it's an immune response. It's a chemical change that triggers that pain response. And so how do we change or control chemistry? Absolutely, there's medications out there that do an amazing job, but movement and exercise do it as well. And so that's where if you're going to physical therapy and you're doing your workout, once, twice a week for an hour and you're doing great, but then you go home and you don't move as much as maybe you should, or you move too much, there's a double-edged sword there. You got to find a balance. I would say that exercise movement, sorry about that, guys. Exercise movement, that all has just as much of an effect on your chemistry related to pain as anything else. So I call it the Goldilocks effects. You want to move enough, not too little, not too much. And then finally, just the sensation. I've worked with so many individuals who have had knee pain for so many years prior to surgery that by the time they actually have surgery, their brain is so conditioned to feeling that pain for so long that they're just used to it. And now there's no reason for the pain, but they continue to feel the pain because those nerves have been hypersensitized to what's been going on for sometimes a decade. So my take-home message here is I wouldn't blame a single muscle for what you're feeling. I think what you're feeling is totally normal. I've got a bunch of videos showing you how to desensitize some of that area. My go-to for you in particular, I would try to put that area on a stretch. So opposite of flexing, right? You feel it when you're flexing. Okay. I would stretch it into extension. I would do a calf stretch, if you know what that is. I try to do a little massage in the extended position. Massage those muscles behind the leg, either with a rolling pin or with your thumbs or ball or anything you find. And then flex the knee into the position that normally produces the pain. I think what you'll find, and I'm totally fine if you prove me wrong, but I think what you'll find is if you spend 60 seconds, 2 minutes, 3 minutes stretching into extension with, pulling your toes back, massaging the area behind the knee, and then you go to flex the knee past 90 degrees, the pain's not going to be there. Give it a shot. Let me know. Don't do anything that feels wrong. You know your body better than any of us, but I'd love to hear what you think. And those of you who are hanging out watching, thank you so much for being on here. If you're not already subscribed to the channel, take a minute, subscribe. The more of you who watch the videos and interact and post comments on YouTube, the more people we can help, because that tells YouTube to get this video out to a bigger audience. Guys, thank you so much. I hope this was helpful. I'll catch you on the next Q&A.